Thank you, Zandy, and thank you, Eamon, for the kind introduction. And a big thank you to the conference organizers for letting me share a part of our infection reduction journey at Cornish Hospital. So I've got no disclosures. This will be the content of the presentation in general. So you've heard all the other speakers throughout the last 3 days, and we know outcomes in neonatology are continuously improving due to the new medications available, new technologies available, and a new outlook to how we treat these infants. And survival is improving world over but what's happening with that is there's some associated increase in short-term and long-term morbidity, and infections always comes up as one of the most important of that, contributing to both morbidity, not directly of the infection, has a lot of effect on neurodevelopment, eyes, lungs, you name it, and it causes problems. And of course, one of the leading causes of mortality world over. So I'm not going to delve too much into this. There's early onset and late onset infection. Generally, for surveillance purposes, we call early onset within the first 3 days. It's linked to maternal infection. There's very little we have control over there, apart from prophylaxis for GBS, which is now being adopted world over. It's a late onset infection, which is usually hospital acquired and is linked to infection control measures. And these are potentially preventable, not always, and we can control some of the factors in that. So the burden depends on which part of the world you are. Some parts of the world kind of reporting up to 50% of very low birth weight infants catching an infection after the first 3 days. In the NICHD network, I don't have the most up-to-date data. The last published, they said 25% of the very low birth weight infants in the NICHD network was getting an infection. And in the developed economies all around the world, it has been reducing over the last many years. One of the studies which Dr. Eamon's group was involved, which is published in the latter half of the last decade, which was a multi-center trial in the Gulf region, showed that in the Gulf region, the infection rates are relatively still high at that time, around 56 per 1,000 admissions. And we've also seen seasonal variations, but nobody's been able to pinpoint what causes those seasonal variations. A brief introduction of the center which I work in, Cornish Hospital. It's one of the largest neonatal units in the UAE. We used to be quite busy till a lot of the other units in Abu Dhabi opened up till 2014. We used to have up to sometimes 10,000 deliveries per annum. It has reduced to around 6,000, but we still have a significant number of admissions to the NICU because of the complexity of the deliveries we deal with there, being one of the tertiary referral centers. So we have anywhere between 900,000 admissions per year. And what happened is 9 years ago, we were a relatively small unit and we were working well over capacity all the time, and they decided let's go up from around 40 beds to 64 beds officially with increase in space and nursing. And what happened, bingo, within no time that was filled up as well. And we were constantly operating above 100% capacity. So as I mentioned, the complexity of the cases we deal with here are high. And we are benchmarked internationally and locally so internationally, we are part of the WAN network, and we look at our data and compare it to the other units on WAN, similar units. We have internal benchmarking and also within SAHA as for infection KPIs. This is just showing you what our occupancy rates are like. So pre-2013, this was our official cot capacity, 42. Then we went up to progressively 64. We were never fully staffed for that, but always, because of the nature of the work we do, we are invariably above 70. So we are more than 100% census most of the time. And we know that once a unit hits about 80% occupancy, all the adverse outcomes start to show, including infection. And we are a bit lumbered with that, not much we can do because of the way healthcare is organized within the UAE. We just deal with it and get on with it. And this is in the last few years, it's pretty much the same picture. Now, this is where we were in 2014 with regards to infections. So I had just joined the unit at that time, and then chair showed me these pictures saying that on WAN, we were well outside the kind of interquartile ranges for all late infection parameters. And he said, can we do something about it? Foolishly, I said, yeah, let's give it a try. I didn't realize how much hard work it was going to be. So we launched a continuous quality improvement initiative since then to kind of tackle these infections. It's ongoing. Infection is not something you kind of reach a point and let up on it. You have to be constantly vigilant, because the moment you take your foot off the pedal, it comes back. So we are continuing to do what we're doing, and I'll share the data of what we've gathered over those 6 years. So these are various definitions of QIP. It's essentially shifting away from old ways and moving towards a new way of problem solving and systems to adapt to evolving challenges. And that's what we do day in and day out. So why would anybody do a QIP in your unit? So these are the general things. So patient safety, to reduce complaints litigation, improve satisfaction, financial. So when you put infection there, it ticks all the boxes. So if a baby gets an infection, parents are unhappy. They might say that you gave the infection to the baby. They'll be unsatisfied with the service. And each infection costs a hell lot of money per baby. It shaves off a good margin of the DRG you get from the insurance companies. So for us, there might be various triggers for starting a QIP. For us, it was a Vermont-Oxford comparison, and also the realization that we did have a lot of infection going on from the trends we were seeing in our risk management committees. And also the morbidity and mortality data, infection kept coming up as the main contributor of deaths on a unit at that time. So just briefly running through various methods and styles of QIPs. You have the PDSA, that's a Plan, Do, Study, Act, and you have the RADAR. These are all tested ways of just doing the same thing. And then we also have the other two which came in from industry, which are kind of adopted in some aspects of healthcare. So we mainly follow the PDSA model in kind of initiating quality improvement programs for infection. So when you look at quality improvement, you have to look at lots of things. Structural, what are the availability of your resources? What are the management systems? What's your policies? And even if you have all those, what is the actual process of delivering healthcare? And then you look at the outcomes and then decide what you want to tackle. And now we have the concept of continuous quality improvement, as I mentioned. It's a continuous process. You don't stop once you achieved. Then you ask yourself, where do we go from there and improve even further? So when we started this project, so I was new here, and so we started doing some scoping exercises. So me and part of the team which I put together started flying the wall observation of what was going on in the unit in terms of hand hygiene, in terms of line care, line access. We went around the unit interviewing existing team members who've been there for a while, asking them what do they think is the problem which is contributing to high infection rates. And we had kind of multidisciplinary scoping sessions, a few of them, to take feedback from both medical and nursing staff, and also emails. So that lasted for around 3 months, and then we focused on certain things which we needed to. We put together a core team, which at that time was one consultant, which was me, one specialist. Since then, we included more specialist doctors, the nurse managers, nurses, nurse educators, and somebody from quality improvement. So we started looking at the data and we started formulating action plans. And we assessed the problems in these 3 domains. So when you look at structural issues, Cornish Hospital is 40 years old. It was designed for 3,000 deliveries per year. And we were triple of that at the time when we started tackling this problem. So if you look at both American, British, and European recommendations, the floor space you need per baby, including all the storage areas, is around 14 meters squared. For us, with even our licensed cot capacity, it was at best 8 meters squared. And when we hit our more than 100% occupancy, we were far below what was recommended. So anybody who's visited our unit will see babies all over the place. Not that we want to do it, but we have to do it because of what is available around. Then we looked at our census. There's very little we could do about that. We started partnerships with the hospitals within the network and also the private sector to say, once we are well above capacity, we start moving babies out who are stable enough. But very often we meet resistance from parents about that, saying that we came to Cornish Hospital for a reason, we want to stay here. Not an easy one to tackle. Then storage area for neonatal equipment, they were being stored everywhere, including the corridors, and of course that was getting contaminated. And staffing, we all know nursing staff are the backbone of our unit. And we know that one-to-one nursing significantly improves in all outcomes in newborn infants when they're in intensive care, less so in the high dependency and special care areas. In 2014, for a licensed cot capacity of 64, we were 39, short of 39 staff to even man that. We have caught up since then, but we are still short because of the high turnover of staff in this region of the world. And also, there is again about qualification and specialty, saying that are they neonatal trained and qualified? A lot of our nurses came from general background of pediatrics, they were not, and we trained them up. So if you look at the BAPM recommendations, they say on a neonatal unit, 70% of your workforce should have specific qualification in neonatology, but ours only 20% had, and we put in internal measures, which was already ongoing at that time and strengthened further by our extended education team to kind of train them up, do competencies and sign them off. And the structural issues were all highlighted to our high management, saying that this is an issue and they need to think about long-term planning on these issues. Policies, we all have policies, so we checked, are we lacking any policies? We had a hand hygiene policy, we had a central line policy and bundles, isolation policies, antibiotic policies, policies for cleaning and waste, excellently, very well-written policies, but there was a complete disjoint between what was in the policy and the care delivery. Most of the times, these were tick box exercises without proper monitoring and delivery. And some of the metrics which were being used are not accurate or fit for purpose. So at that time, our infection control practitioner was collecting the data and was presented at infection control committees and everything. But the frontline staff on NICU were not aware of that data. Then in terms of hand hygiene, as I said, there was a policy in place and the infection prevention is also showing a very high rate of compliance, somewhere in the 98 to 98% mark. But a fly in the wall observation revealed a different story. People were not compliant, and non-compliance was widespread. One of the things which we noticed, it's human nature. It's easy, you do it. If it's difficult, you don't. The access to hand gel. So most of incubators had these holders which had been missing for a while. Hand gel was stored in our busy NICU spaces. So people kind of cut corners when they were busy, sometimes forgetting to gel their hands. And we had residents coming in from our sister hospital to do postings there who were not properly oriented to infection control policies and not adhering to hand hygiene techniques. And parents, again, they're an integral part of what we do, and their training and monitoring was not happening at all. And people are afraid to kind of approach parents and tell them, do your hand hygiene in this way, and you have, or if they hadn't gelled their hands. And we were kind of encouraging the staff to stand up and be brave and do it in a polite way to kind of enforce this. Another bane of my life, mobile phone use in the clinical area, it was widespread. This is one of the most dirtiest pieces of equipment we carry around. People are leaving it on patient care surfaces, handling it all the time. And there was no publicity of hand hygiene, not even a single poster on the unit saying this is important. Look at central lines, bundles were in place, and as reported, the compliance rate was very high. But when we actually looked at it, it was just paper compliance in terms of the tick boxes. So what was happening was the doctor used to do the procedure, the nurse assisted. At the end of it, they just ticked the boxes and submitted it. And there was no employment of our nurses to stop the procedure if our medics breached any of the infection control measures in that bundle or the bundle monitoring form. And there was no standardization of how we fixed the lines. Everybody was doing what they learned in their previous place of work, and that was a problem. And the use of antiseptics was another issue as well. We had 0.5% chlorhexidine, which is on a tiny little stick which didn't cover the entire skin area, and we looked at that as well. And throughout the day, our nurses were having to break into the line multiple times, once to hang up the TPN, the next time to hang up a dopamine, it might be insulin, and that had been going on for a while. And this is controversial, even within the Sahar network, we discuss this a lot. The duration the lines are being left in. I know the large data sets from the US do suggest it doesn't matter, but we have to look at what was happening at our end. So this is some of the problems we noticed. So people are using this stick to clean the below 28 weeks, and they were rarely covering the skin area which was being handled at the time of insertion. tiny little drapes were being used with a lot of the bed being exposed. The tick box exercise was happening, and all these fluid changes, the fixation, the hub was exposed quite a few of the times, and people fixed the line where they deemed fit. So again, about the data, as I said, the data which was being presented did not actually reflect reality. And there was a general feeling that everything was being done, we can't do any more, and accepting status quo. So we put together this team called the Neonatal Infection Team, task force, and we decided to challenge the status quo. So we started with monthly meeting and said that we have to influence change, standardize things, publicity, education, collect data within the unit and kind of publicize it and go through PDSA site to see where we are getting at. So structural changes through our management at that time, we acquired one extra room in an adjacent ward to kind of decant our low-risk SCBU babies so that we're not crowded on the main unit. Our staff recruitment continued to improve. We are actually currently in the 170s mark, so hospitals and have supported us in a big way in achieving that. Storage area, we acquired a storage on a different level where all incubators and equipment were stored and brought in only when needed. The incubator cleaning, which was happening with CSST, was brought in-house to kind of monitor it more closely. And there was continuous education. So we introduced what's called the lesson of the week. So what we do is at every handover, we read out, this is what we need to do. So just to send out message to staff. And that was continuous for the first year. We also sent out emails with our data as we got it so that people realize where we are. And this is just Dr. Akuma, my colleague, reading out the lesson of the week on one of the handover sessions. Data, so this was what was coming from the ICP team with a very high compliance in hand hygiene, relatively high compliance in insertion bundles and maintenance bundles. We created our own dashboard looking at our infection rates and central line bundles. We started doing spot checks and double checks to see what the compliance was, and showed a completely different story. Our insertion bundle compliance was actually only 71%, where the data which was being given to us was saying it was more than 90%, which is just a paper compliance. Maintenance bundle compliance was far below. So there was a problem. So we started making slow improvements. The first thing was the patient environment. We made sure every incubator had a gel holder. And one of the things our staff fed back is when medications come, including IV medication, they've just been left on top of the incubator. So we said each baby needed to have a clean tray for the medication to be placed so they're given and cleaned regularly. We changed the computer keyboards to sealed, cleanable keyboards, which had to be cleaned every shift. And hand hygiene was a central focus. As you all know, that's the most important intervention we can do to kind of prevent infection. So we had posters, education, banning on mobile phone use in clinical areas, road shows, free access of gel everywhere, and data collection and feedback. And if there were breaches, one-to-one feedback were given on the spot. So with hand hygiene, so this was a PDSA cycle we went through. So we planned to collect data and we said we needed to validate. We started mystery shoppers and we realized there was discrepancy in the data and also the way data was collected. So we standardized the data collection form. Then we started with the education again, road shows, lessons of the week. We collected data again, and it was a continuous cycle. Central lines, we updated it. It was a pretty basic guideline, so we updated on exactly what we expect on the unit. Procedures including standardized fixation, insertion competency assessment for all doctors. These are doctors who are very competent in putting lines in, but what we were assessing was the aseptic technique. So we made sure everybody stuck to what we wanted them to do. The antiseptic solution, because of the nature of the swab we were using for the lower concentration, we said all babies should be cleaned with 2% chlorhexidine. I'll come back to that in a minute. And we updated the care bundle monitoring sheet to kind of make it fit for purpose. So this is some of the training we did with simulation, how we are supposed to drape, how we're supposed to fix, and the use of at least 3 swabs while cleaning and cleaning just before you insert, and so on and so forth. We also embarked on a small research project, which one of my fellows did. And when we looked at our data, the babies who developed eclampsia, an infection with the line, most of them happen once they cross the 2-week mark. And there is some study, I think the Adam Millstone study from the US, which said the same. So based on that, we said we'll change to a 2-week maximum duration of lines, either it comes out or we electively replace it. I know this is very controversial. A lot of people will push back on this, but we implemented it because we were desperate at that time. And we were reviewing lines daily and making sure it came up when it was not needed. The other thing we did, the way our unit is organized, our intensive care rooms are organized into 4 rooms with 8 babies officially, but we have up to 10 or sometimes even 12. We said each room, all the infusions will be changed at the same time on a particular day. So there's one line break at best in the 24 hours. If we needed anything more, we could do it. So these are like routine TPNs, infusions, and everything. And every CLAMP-C was reviewed in detail to see what went wrong and what we could have done better. So we went through multiple PDSA cycles. So the first one was standardization, kind of do a guideline, checklist, and training, and we presented the data back to our staff continuously. In the second PDSA cycle, we looked at the line duration. Again, we collected the local data, and we decided to go to 14 days. And the third one was about antiseptics when we introduced a 2% chlorhexidine. What we immediately realized, we were getting a lot of skin injuries in the extreme preterms. So we sourced a new product with 0.5%, which could be applied a bit better. And since then, we haven't had any more skin injuries. And by the end of the 4th cycle, all the practice is embedded. But from time to time, it slips, and we have to go back and retrain, reinforce, and re-educate. And over the course of the first year of implementing this, our infection rates are gradually coming down. A lot of our internal KPIs and external KPIs went to green. And our infection rates in 2014, where the late onset BSI had been around 6.4, dropped to 4.7 by the end of the first year. And it continued into the next many years. So this is what we achieved over the course of the last 6 years. Having had a starting point of 6.33 late onset bloodstream infections per year, we came down here. The last 2 years, we stagnated a bit. We're slightly better this year. But one of the worries we have this year, gram negatives have gone up slightly. There were reasons behind it. We had some chronic babies with chronic bowel issues who were extremely preterm, who were kind of contributing to this data. But our cons infection rates have continuously come down, except last year where we had a spike. So whatever we've done seemed to be working. And this was, again, correcting it for 1,000 admissions. So as I mentioned, in the Gulf region, a few years ago, the reported was around 56 per 1,000 admissions. When we first started, we were somewhere here, 160, and in the hundreds. Progressively, we've been able to bring it down to what our rest of our sister units are doing around the region. We're probably slightly below now, but still, we've got a long way to go. My markers of the WARN data medians have disappeared from the slide. This is just comparing to what we are still outliers on WARN. We're not finished with this yet, and there's still work to be done, but we are still hopefully moving in the right direction. So in summary, what I wanted to say is bloodstream infections are preventable, regardless of which part of the world you work in, even with resource constraints and space constraints. Benchmarking both internal and external is important. Make sure it's fit for purpose for your unit. And a continuous quality improvement methodology is a powerful tool to monitor outcomes and build on success. And it's a journey. It never ends when it comes to things like this. We do have hiccups along the way. And we hope at some point with our new hospital potentially opening up in the next few years and proper planning of space, we might get to where we need to be. And that some of the team members have contributed very actively to this initiative. Of course, all the staff on the unit have worked quite hard, and I wish to thank all of them. And thank you to the organizers for letting me present this data.